This conference will now be recorded.
Welcome in, everybody. In today's lecture, we're going to be covering chapter 19, which is going to be seizures and syncope or syncopal episodes, very common emergencies that we're going to come across as being EMS providers. So let's dive in. This is going to be our objectives throughout this lecture. Make sure that you are reading the entire chapter as well. I am going to be going through the entire chapter and all the contents. This PowerPoint is actually created by Pearson. So first, let's take a look at the case study. So EMTs enter residence for a report of a seizure to find a man in his early 30s. Unresponsive, increased respirations, heavy oral secretions. They can see the patient is incontinent. Patient's brother reports that patient was playing a game of cards when he experienced the seizure and then fell out of his chair. So when we're looking at this study and our first priorities of the assessment and care, remember, we're going to be going through that primary and then also our scene size up. Is the scene safe? How many patients do we have? Do we need additional resources? And again, we're operating right now as a BLS level crew responding to a seizure. So we should keep in mind, do we have advanced life support capabilities that are going to be responding so that they can provide medications to control that seizure? And then also thinking of that C-spine precaution consideration. Oftentimes when somebody seizes, they fall from a standing position, and because they have that altered mental status, we can't rule out C-spine precautions at that time. Then as far as additional information for seizures, very important that we get some criteria. First, does the patient have a history of seizures? If they do have a history of seizures, are they taking their medications properly? Have they had an adjustment to any of their medications? Another key piece of information that we always want to know is how long that individual seized for, and did any care providers give them any medication and try and control that seizure. If the individual does not have a history of seizures, we need to dive into what was the patient doing prior to the seizure starting, because there could have been a secondary cause that actually tricked that seizure from occurring, and we're going to talk about that later on. And then lastly, does this patient require transport to the hospital? And we'll talk about more with refusals and then getting into that patient care aspect. History of epilepsy, it was a mild seizure, maybe it only lasted 30 seconds. Patient went into their postictal phase and now they're alert and oriented. Yeah, they might not need to go to the hospital as long as somebody else is there to provide care. But if they're still altered, if they seize for an extended period of time, if there's no history of seizures, then this individual is going to need to go into the hospital. So what a seizure is, very similar to the cardiovascular system in which we need proper electrical function in order for that heart to work. We also need proper electrical function within the brain in order for that to work properly. So when somebody goes into a seizure, it's a mismatch of electrical rhythms that's actually being conducted through the brain. So what we could see as far as signs and symptoms go is violent jerking movement. We could see somebody basically staring off into space. Again, every seizure is going to be a little bit different depending on our patient, and then depending on what hemisphere is actually being affected by that impulse of that electrical activity. The common causes, the most common cause that we're going to see with seizures is somebody who's predisposed to seizures, and that's going to be classified as a medical term epilepsy, which means they have a history and disposition to actually having seizures. So, pathophysiology. When we're looking at unprovoked seizures, this is occurring from basically epilepsy. It's passed down either genetically or there's something within their DNA sequence that actually causes somebody to be disposed to have an epilepsy. Epilepsy, so we could see simple partial seizures and or complex partial seizures depending on what hemisphere of the brain is actually being affected. Generalized seizures are going to involve both hemispheres of that brain. So when both hemispheres are affected, we see that violent jerking movement. When we see simple or complex partial seizures, then generally one body system is going to be affected. The other types is going to be secondary and or provoked seizures. So this is somebody who may not have epilepsy, but a outside circumstance occurred, and as a result, that individual had a seizure. So our most common causes of those secondary seizures: high fever. This is going to be for our febrile seizures, specifically within our pediatrics and our infants. And it's not necessarily the high fever, it's that rapid onset of that fever. So we have a massive jump in body temperature, and that massive jump actually causes that patient to seize, because our brain needs to maintain a certain temperature in order to function properly. So very similar to the infomercials for those of us who are older in the class: this is your brain on drugs, and they would fry an egg. That's basically what's occurring when somebody has a very high fever and or is suffering from hyperthermia. Could also see non-compliance with seizure medication. Very common for some of our adolescent patients who have epilepsy and are starting to get into that resilient or rebel phase, or they might not take their medications properly, and or maybe the doctor prescribing them a different medication. Their body needs to adjust to that difference within that medication. Poisonings and infection can also cause a seizure. Specific poisonings, stuff underneath the kitchen sink, oftentimes can cause a seizure. And then also our synthetic-based medications and some of our man-made medications. Specifically, when we're looking at bath salts and synthetic marijuana and stuff like that, that causes a lot of individuals to seize. And we learned about diabetes. The brain only needs three things in order to survive. It needs sugar, water, and oxygen. If an individual's blood sugar is so low, it could actually send them into a seizure as well, and or hyperglycemia, where we have too much sugar in the system. And then traumatic brain injury, severe blow to the head can actually cause that. And then a patient going into shock, because eventually we're going to deplete the oxygen to the brain when somebody's hypoperfusing. Others, not as common as the first page, but something that we can still see. Could see a stroke that ends up into a seizure because we have that mind-altering either blockage and or hemorrhagic stroke from a burst blood vessel. Could also see it from alcohol and drug withdrawal. And it's because the brain gets so used to having alcohol in the system and or drugs in the system consistently. And then as a result of that, that's how that brain operates now. It needs some type of substance, whether it's drugs or alcohol, in order to continue to survive. And so when we immediately withdraw from alcohol or drugs, now the brain is missing that certain piece that it's been used to as far as operating, and that could send that patient into a seizure. And then the other ones that we could also see, again, a little less common, but we could see high blood pressure, pregnancy complications when somebody has high blood pressure within eclampsia, that could send them into a seizure as well. And then our electrolyte imbalance, our sodium and calcium channels. So diving into some of the terms specific to seizures. So when we have status epilepticus, this is a generalized motor seizure. Usually it's going to last for more than 30 minutes. And that patient will seize, they'll stop seizing, and then they'll seize again. But the difference between consecutive seizures, so saying that somebody had 6 seizures in comparison to somebody who's status epilepticus, is the fact that they never regain consciousness. Now, this is a severe life-threatening emergency. This can kill people, because when somebody's seizing, they don't breathe adequately. So oftentimes their oxygenation within their system is depleted at that point. So generalized seizures, When we're looking at the types, we can also see tonic-clonic seizures. So this is going to involve both hemispheres of the brain. Patient is not awake, they are not aware of this occurring, and oftentimes we're going to see violent jerking and movement from all of the different portions of the body. So our stages when we're leading up to that seizure, oftentimes patients will describe an aura. So an aura is a abnormal smell or an abnormal taste, maybe a vision sequence. And once they see that aura or experience that aura, oftentimes that's a trigger that that individual is then going to begin to seize. So one of my patients described the taste of rust and or the smell of burnt toast could also be an aura, just some goofy things that a patient might experience. Then they're going to lose consciousness, and then they're going to go into the tonic, hypertonic, and clonic phase, and in which they get rigid, and then they begin to convulse. So once they lose consciousness, this is the beginning of the seizure, and once they go into the postictal state, that is the end of their seizure. So once they stop jerking, and then they start to come around, that's that postictal state. So here we can see the different phases. In slide A, that patient is staring off into space, probably experiencing that aura, loses consciousness, and begins to get rigid. C, that patient begins to jerk violently. And then D, that patient is now in that postictal phase. So that postictal state is that patient beginning to regain consciousness. Oftentimes they're slow to reflect on what occurred during that seizure. They can be violent, they can be agitated. Regardless, the reason of that is oftentimes their oxygen level is low, and also their brain is resetting to the normal electrical activity. So as far as medical care, when we are performing emergency care for somebody who's got a generalized tonic-clonic seizure, when we arrive on scene, if that individual is still seizing, remove anything that actually could cause more harm. So our tables, our chairs, anything that actually can fall into that patient, and then just let them seize. If you have not called advanced life support yet, go ahead and notify dispatch to send you an advanced life support ambulance, because if they continue to seize, we need to give them some medication in order for them to stop seizing. Once they have stopped seizing, go ahead and treat your patient, get a full set of vitals on them, maybe provide some oxygen therapy if their O2 sats are low, and then be mindful and considerate of that patient. Now, a lot of individuals, when they have a seizure and they're predisposed to seizures such as epilepsy, are going to try and refuse care or deny care or even deny that it happened, because some individuals will lose their driver's license based on how many seizures that they have within a year. So follow your protocols and your guidelines, whether this patient is actually able to go ahead and refuse care for that point. Other generalized seizures that we're going to discuss: absence seizures, myoclonic, tonic, atonic, and febrile. So first, when we're talking about partial seizures, this is going to be one area of the body, and it's because it's one area of the brain that's affected. So the patient can be awake and aware at this point, and it could just be an abnormal body movement. So maybe it's arm twitching, maybe it's eyelids flickering, something like that. Simple partial seizures is going to be that categorization. For emergency care for something like this, when it's a motor or sensor autonomic or psychic seizures, basically we're just going to let them seize, and eventually that seizure most likely is going to go away on its own. As far as taking a patient into the hospital and further care, get a full set of vitals. If that patient does have a history of this occurring, chances are you can go ahead and do the proper documentation as far as refusal goes. If this has never happened, maybe you're going to have to bring that patient in because there's something goofy going on at that point. So with complex partial seizures, the patient could be awake and or unconscious, but they're not going to be aware of what's going on in comparison to our simple partial seizures where they were alert and oriented and they did know what was going on with that point. Oftentimes this is going to start by just a blank stare off into space, and then they are not going to be able to respond to commands. And again, this is going to be one hemisphere of the brain that's going to be affected. So we're going to go through our same emergency medical care that we've done with our other types of seizures, get those sets of vitals, make sure that they don't harm themselves anymore. Our secondary generalized seizure, again, which is a partial seizure, typically this is going to be our generalized tonic-clonic seizure. So full body movement, both hemispheres are going to be involved at this point. So let's take a quiz. Description that best characterizes a simple partial seizure. So jerky muscle movement localized to one extremity, that seems to fit. Full body rhythmic muscle contraction and relaxation, that does not, because simple partial seizures is only going to affect a small portion of the brain. Staring into space with brief loss of awareness accompanied by rapid eye blinking. Now remember, simple partial seizure, the patient is still alert and oriented. So this is going to be a complex partial seizure. Awake with loss of awareness, bizarre behavior such as repetitive movements. So our assessment-based approach for an individual experience in a seizure, we're going to conduct our scene size up, again, number of patients, BSI, scene is safe, look for your surroundings, look for an exit plan, how many patients you have, additional resources, and C-spine precautions. We get in, we assess the scene. If there's still seizing, remove that, any type of dangerous activity that could cause harm to that patient. If not, begin to support that patient in the event that they are postictal. So there we can see this EMS provider, they're moving furniture out of the way, they're letting them seize. Then we're going to dive into our primary assessment, which is going to be our airway, breathing, and circulation. And then we're going to assess that transport priority. So if they are done seizing, they're in the postictal period, assess that airway. They might have vomited, they might have bitten their tongue and or their lips, so they might have blood and secretions in the airway. Make sure that we suction that out and or advise them to clear their own airway. Based on their breathing and oxygenation, so look at their respiratory rate, their rhythm, their quality, look at their skin condition to see if there's any signs of cyanosis, and then also check their SpO2 levels. If there's anything wrong with that, go ahead and assess and assist with oxygen therapy, and then assess their circulation as well. Skin condition, whether that patient still has a palpable pulse. So there we're under the airway, we're suctioning that patient's airway. Once they get into the postictal phase too, it's a good idea to put that patient onto their side, which is their recovery position. In the event that they start vomiting, now you got a better way to suction that airway and that patient's not going to begin to aspirate. Remember proper suctioning techniques, never suction beyond what you can see, never suction longer than 10 seconds, and we always suction on the way out. Once we dive into our primary assessment, when we're looking at transport priority, this is the big keys that we're going to identify that this is going to be a load and go, an emergent transport of this patient. So if they remain unresponsive, if there's something wrong with the ABCs and specifically we can't fix it, if that patient is still seizing, and or we have a significant history of pregnancy, diabetes, and or head injury as well. Other circumstances, again, drug or alcohol withdrawal, epilepsy, or other seizure disorder that is not known in that specific patient, and or significant head trauma. When we dive into our secondary assessment, what we're looking for is any signs of trauma. So when we're doing our history as far as any bystanders on scene. Did that individual fall and hit their head and then they began to seize? Or did they seize and then fell and then hit their head? And then also do a good thorough head to toe assessment of that patient's body system to look for any type of secondary injuries. Get our baseline set of vitals. Our vital signs oftentimes are going to be elevated for our patients, especially in that postictal period. Heart rate's going to be high, blood pressure is going to be high, respiratory rate's going to be high, their SATs might be a little bit low, their blood sugar might be a little bit low, even if they don't have a history of diabetes, and even if it wasn't caused by low blood sugar, depending on how long that seizure lasted, that violent jerking movement actually uses up a lot of sugar stores within the body. So medications that we're going to see that are very common for patients who experience epilepsy. Here's a list. I'm not going to go through them because I can't pronounce them correctly anyway, besides clonazepam and diazepam, which are the two most common medications that we're going to see. But again, there's a lot of different medications depending on who the provider is and depending on who the patient is. So never hesitate to remove your phone and Google up medications, because there is nobody in this world besides probably the top-notch pharmacist who's going to be able to rattle off all the different reasons why somebody takes medication. Just be mindful if somebody's watching you on scene and you're looking at your phone and they give you a curious look, just go ahead and say, I'm looking up this medication. Don't give the specific medication, just say, I'm looking up a medication, so that we're protecting HIPAA stuff. So back into some secondary assessment signs. Again, we're looking for if that patient is able to relay this information and or bystanders, loss of consciousness, how long they convulse, did they bite their tongue, excessive salivation, did they experience that aura. A lot of patients will become incontinent as well, and they can become very embarrassed about that. So if you can do your best to protect your patient and protect their feelings as well. We already talked about positioning the patient properly, get them in the left and or right lateral recumbent position, suction the airway as needed. If that patient needs airway support or if they remain unconscious in that postictal period, oftentimes they're going to snore because they can't remove their tongue away from the trachea. So this is where you're going to go ahead and insert the nasopharyngeal airway if needed at that point. Talked about our ABCs, very important: suction, oxygen, ventilations, transport as needed. Patients do have the tendency to seize even after they have gotten done seizing and are out of that postictal period. So be mindful and be ready for that. Remember never to hold down a patient when they are seizing. So if you got them in the stretcher and they're secured, go ahead and loosen up those buckles. If you're already in mid-transport, have your driver stop, loosen up the buckles, and have that patient go ahead and seize. So this is the textbook's definition as far as your emergency care protocol. So very similar to all of the emergency protocols that you're going to experience once you get in to your specific service. So we're going to move on to syncope. Syncope and or syncopal episodes are going to be a rapid onset of loss of consciousness. So this is going to be caused by a variety of different things, but the common cause is going to be an increase to the parasympathetic influence. So difference between syncope and seizure. Syncope usually is from somebody standing. Seizure, it's going to be in any position. Oftentimes, syncopal episodes are caused by low blood pressure, so they might complain of lightheadedness or dizziness. And then we're going to see that individual lose consciousness, go to a prone position, and then eventually they're going to come out of it, and they usually come out of it relatively quickly depending on what that cause is. We're not going to dive too deep into the seizure content since we just covered that. So somebody has a syncopal episode and or you're called to somebody who has passed out. You arrive on scene, get that patient into a supine position, be mindful, and talk to any bystanders about whether that patient needs C-spine control from any type of trauma-related stuff, and then determine that transport. Any patient who loses consciousness for an unknown reason should be seen at the hospital by a doctor, even if we have the highest index of suspicion that we know what caused that syncopal episode. We can't diagnose in the field, so that patient still needs to be treated and transported to the hospital. So the patient has a syncopal episode. Here, this rescue provider is conducting a head-to-toe exam, starting with the head to try and identify if there is any head injuries to the head. So our case study, Anna and Lauren turn the patient, Dan onto his left side, and Anna suctions his airway. Dan is responsive to painful stimuli, has adequate breathing. His skin is warm and moist. There is no cyanosis. His SpO2 is 99%. The seizure lasted about 2 minutes. Its description is consistent with tonic-clonic seizure and looked like seizures Dan has had in the past. So we check the head, we check the trunk, we check the extremities, and it appears that Dan may have bitten his tongue at some point. He does have a history of seizures. He does take a medication to control those seizures. We do a quick check. Prescription bottle shows that Dan may have missed several doses since this prescription was filled 2 weeks ago. Dan is now responsive to verbal stimuli, but because his mental status remains altered and has not been compliant with his medications, Anna and Lauren recognize that he should be transported to the hospital. En route, Dan becomes more responsive, but remains sleepy. The EMT turns his care over to the ED staff with a complete report. So when we're diving into what caused the seizure, most likely it's going to be the result of Dan not taking his medications. Anna and Lauren did the correct thing by encouraging that patient to be transported to the hospital so that they can continue to mind and take care of that patient. So let's go through a brief summary. Seizures, result of abnormal electrical activity. They can be generalized or they can be partial. Generalized is going to be both hemispheres of the brain. Partial is going to be one hemisphere and or a simple partial seizure of a small area of the brain being affected. And as a result, that would be one body system. Status epilepticus, this is going to be consecutive seizures that do not have a time period in which that patient regains consciousness. Oftentimes, it's going to be about 30 minutes or more. Syncope, this is going to be a result of interruption of perfusion. So this could be caused by low blood pressure. This could be caused from an individual standing for a significant amount of time with their knees locked. This could be a result of severe bad news called the broken heart syndrome, and in which case it triggers that parasympathetic response. It could be from hypovolemia, low fluid, cardiac dysrhythmias, certain medications. The list goes on, and that's why it's always important to transport patients with a syncopal episode. All right, that concludes chapter 19. I hope you guys enjoyed this content conducted by Pearson. If you have any questions or concerns, please reach out, and we will be talking about chapter 20 next. Thanks.